Right. Hello and welcome, everyone. My name is Sarah Webster. I'm a knowledge broker with Niagara Connects. And thank you for joining us today for a webinar on mapping crisis services in Niagara. Our chairperson in our online meeting room today is Sarah Johnson, who's also part of our team at Niagara Connects. And we're happy to have you join us and fellow presenters today to hear a little bit more about what's happening with respect to crisis services in Niagara and some directions that we're going to be moving from here. So for those of you that are new to webinar technology, the voice that you're hearing right now, my voice, is coming through the phone line, and then the visual of the slides is provided in the online meeting room. All of our participant lines are muted, and that helps us cut down on some of the inevitable background noise of dogs barking and fire alarms and PA systems. So we encourage those that are joining in groups to have conversations within your own space there. You are muted. But certainly if you have any questions at all during the presentation, feel free to use the chat pod down the left-hand side of your screen to just type in any of your questions. We'll keep an eye on that and hold on to them until the discussion period at the end of the presentation. In addition, through Niagara Connects webinars, we do record all of our events like this, so those recordings will be made available within about a week. We'll send out a communication to everyone who registered for the event with a link to that recording as well as the slides from the presentation today. So certainly feel free to pass that on to any colleagues who may not have been able to join us. We'd really appreciate that. So in terms of agenda, I'm going to turn it over to George in just a second. We've got George Kurzawa here, Ernie Jodoin, and Lindsay Galipeau to talk to us a little bit more about crisis services in Niagara. So as George starts to say his hello, I am going to pull up a poll on the screen. And for those in the online meeting room, if you can take a second and just answer the question on the screen to tell us a little bit more about which of those three resources or services you're familiar with. George, I'll turn it over to you.
Thank you, and welcome. I'm George Kurzawa. I'm the Executive Director of the Canadian Mental Health Association, and we're pleased to be able to present this webinar here today. First of all, the purpose of our webinar is we want to develop an awareness of our efforts to develop the cooperative system of crisis care in Niagara for individuals with mental illness, substance abuse, intellectual disabilities, youth and adults, and others who are in crisis and require some hospitalization. So that's the overall general purpose for this webinar. Some of our key objectives are to identify some of the themes that we want to work with regarding crisis care mapping project, which Ernie is going to present. And finally, we're going to be demonstrating how the mobile crisis team operates for us as a result of all of our efforts through the charter, through our systems review of our Niagara Crisis Mapping project as well. What I'd like you to consider are three questions as we're doing our presentations. What is missing in crisis care? So something to think about as you hear us talk about the issues. What are you doing right? And should we continue in terms of crisis care in Niagara? And what are we doing wrong and we should stop? So some simple questions to think about. Anything else, of course, there'll be a question period at the end. I'm going to start by giving you an overview of the charter. Our charter, for those of you who aren't familiar with it, our Mental Health and Addictions Charter is unique in North America, and it's probably unique globally as far as we know. We do have a common agenda, which we've created for children, adults, families living with mental illness and addictions, so that they can achieve their optimal well-being. There are 65 organizations that have signed on to our charter. Optimal well-being is dependent on all of us, not just service providers working together to raise awareness and educate and coordinate our resources for world-class services in Niagara. And we believe we can do that, and the charter is a starting point. There are 9 principles in the charter, from a focus on promotion and prevention to a commitment on continuous evaluation. The presentation reflects many of the principles identified in the charter. So, for example, information and sharing of information is critical to access and the development of services. And this webinar is a piece of that information principle. Another example, key principle, is partnerships. And there's a clear principle evidence in the report that you'll hear from Ernie, and critical to the development and sustainability of the mobile team. Without a strong police, community, and hospital mental health partnerships and other mental health partnerships, our mobile teams would not be a success. So that's part of the collective impact that makes our programs function and the charter realize its full potential. I'm going to talk a little bit about collective impact now and what that means, because it's important to the ongoing development of a system of care in Niagara, and especially as we continue to talk about our crisis services. There are 5 conditions for that collective impact. Common agenda with a shared vision, which is the basis of this mapping study. Shared measurement, collecting data, measuring results, and we're going to share our data and results from the Mobile Rapid Response Crisis Team. Mutually reinforcing activities. There's currently a committee, many of you who have participated. It's operated through the hospital. It's working to develop transitional care between services, for example. And as you know, transitions between services, and especially between the hospital and community, is critical to the satisfactory outcome for our clients. Over time, we have come to realize that we don't function in isolation. For example, hospital objectives of stabilizing clients.
George, I'm sorry to interrupt. It's Sarah here. We do have a few comments coming in that you're very difficult to hear right now.
Oh, okay.
Is there any way that you can move as close to the phone as possible and just speak at your maximum volume?
I will do that. Okay.
Thank you.
I'm holding this large contraption now. Okay. Continuous communication. This webinar is part of the continuous communication needed to assure constant feedback. Next week, the Charter Reference Group will be meeting to plan another community-wide event informing everybody about our success and struggles with the implementation of the Charter. And finally, backbone support. Niagara Connects has been a principal partner in developing the Charter and supporting operational initiatives. It's like a strategic plan. It just sits on a shelf unless someone picks it up and works with it. And that takes an organization like Niagara Connects to realize the potential of the Charter for improving our mental health and addiction services. So that, in a nutshell, is how the Charter continues to influence our services and our planning. And I'm going to move it over to Ernie now to talk about crisis mapping.
Can everyone hear me? Well, we're starting to get just a couple of comments. I hope the volume will improve. I'll try to speak as loud as I can. Thank you, George. My name is Ernest, and I'm a consultant on the project for CMHA. I'm also on the clinical faculty of the School of Nursing at McMaster University. So I'm really happy to be here and talk about the crisis mapping project. Really, crisis mapping was to provide an overview of crisis services in Niagara region. Essentially, it maps out the intersecting crisis services and urgent supports. It also allows for a review of challenges and opportunities, and also to recommend options to improve access and integration. The system mapping work that we did was really modeled on the Taylor-Newberry work in Peel region for Peel CMHA and Peel United Way. Again, as you identify here, the system mapping provides some information about inflow, flow through, and outflow to and from Niagara's crisis services. In so doing, it helps also to illuminate issues and challenges for discussion, and also to put forward recommendations to improve coordinated and integrated systems. Just a few slides about what is a crisis: the inability to cope, risk to self and others, severe emotional distress. These comments or components really emanate from the standards in 2005 for crisis services. Crisis services themselves are to enable immediate access to persons in crisis, to help people deal with the immediate crisis and restore them back to some level of higher functioning. It's time-limited services with the intent to stabilize the situation and to ensure urgent access to a range of longer-term supports. And just to comment further, the standards that were discussed in 2005 ensure that the intent is to ensure that crisis services are a core services and are coordinated and integrated with the formal mental health system. And some of you may know at this point that the Ministry of Children and Youth Services has also put out standards for core services, which include crisis services, 24-hour access to coordinated and integrated crisis services. Another type of services we'll be referring to momentarily are urgent supports. Urgent supports help persons through a crisis, and for example, withdrawal management services, safe beds, and CMHA urgent support services are examples of urgent supports. The key here is that the person is at least stable enough to participate in his or her care, has been stabilized, understands the need for help, and can actually participate in follow-up care. As a general orientation, we developed this continuum of crisis supports in Niagara. So you can see across the top, crisis services, what types of clients they serve, what services are accessible in Niagara region, and what are the general outcomes service goals for clients. Urgent supports are short-term. Clients are relatively stable, can participate in their care, and there's some examples in Niagara of urgent supports, including victim services, mental health and addiction access line for access to other services, emergency shelters, and so on. And finally, more longer-term follow-up support is listed, including NHS outpatient services, ACT team, victim services, peer support, and consumer survivor initiative. This is, again, there's flow to and from. This is not necessarily carved in stone, but it was in the first attempt to at least try to understand what services fit to serve different types of clients and what would be the expected outcomes. The key is that it's an integrated system across both horizontally and vertically. So moving on to the project, these were the key questions in our focus groups and interviews. Describe your service. How do persons get connected? What is the flow through and throw out of your program, if you will? What are the common issues and challenges and gaps? What are suggested improvements and options to move forward? This slide really shows the amount of interviews and focus groups that we had. So 12 agencies were involved, representing about 17 programs, 29 participants in total in the interviews, 10 maps completed, 10 one-on-one interviews, and 6 focus groups. So it's quite extensive, and we want to thank everyone for participating. In addition, once the report was completed, we sent that back out to the community for consultation and any changes to the report as recommended. As a general orientation to crisis services, we try to delineate what's a typical crisis call. And you can see across the top, from the crisis situation, access may be through the 911 system, access may be through the distress center and linked to the COAST program, and access may go through the Pathstone Crisis Services for children and youth. The other thing I would mention other than the 911, at the time, back in June 2015, the Mobile Crisis Rapid Response Team was not in place at that time. As you can see on the left, essentially through 911 earlier, police services would have to deal with a crisis and take the person directly to the ER at the NHS, and through the PERT team either be admitted or discharged to follow up. But now we have an excellent service where the police, tied with mental health workers, can can intervene directly in the community and possibly defray any transport to emergency if the case is stable enough, and then can go to other longer-term support. We'll be talking about mobile crisis momentarily. The next few slides, I won't dwell into much detail, other than to say that these are some examples of the. I think I'm going to be presenting about 3 or 4 slides of the maps, coast mapping. Here we have a system mapping for the coast mapping, showing the key referral agencies for the coast program, what happens through coast, including outreach service, support, follow-up, and referral, and finally the major referral destinations for coast. This might be overly simplistic because some cases obviously there may be police involvement, judicial involvement, and that sort of thing, so that the feedback loop may be a little bit different, but we just wanted to keep it simple, just showing the major referral, flow through, and flow out. And the next example would be pass-down mapping services, showing the major inflow, flow through, and referral destinations for pass-down. Safe beds mapping. We'll come to safe beds momentarily. This is an evolving service. I'll talk about that momentarily. And the last example would be the NHS PERT team, showing the major referral into PERT. And PERT, as you know, would have a 4-bed assessment unit, coordination of admission, care planning, and referral, and there are other major referral destinations. Again, not all inclusive, but just the general flow in and flow out of the PERT program. Finally, in the last couple of minutes, I wanted to talk about some of the major recommendations in the report, and I want to point out that this report was done about 5 to 6 months ago, and we have a lot of activity in the community since then in terms of many of these directions. So some of the key ones I'm going to mention right now around the protocols and service agreements required between the new mobile crisis rapid response team and other agencies, including Pathstone, NHS PERT, Coast, and Safe. And it's interesting for Pathstone, this is a service for children and youth, and they have signed on to work closely with the mobile team for children and youth from 0 to 16, I believe, for children and youth in distress in the community. So there's a link there. On the referral side, NHS PERT has done an enormous amount of work with the community around developing standardized referral and discharge forms. So no longer will a person be sent to you without follow-up information from the hospital about what had transpired and what's the design for a care plan for that person. Similarly, all agencies are requested to be involved in developing, using the PERT referral form for cases that may be directed to the hospital. In addition, a couple of months ago, there was a session at the Club Roma around the development of a crisis plan. So persons, particularly those who may be frequent users of the system and the hospital, it would be suggested that there be a database for an individual crisis plan for when that person is involved in the system. There's information about how to go about treating that person, discharging, and doing the follow-up. Also, the NHS transitional discharge model is part and parcel of that plan. No longer are we really trying to have person not integrated and not coordinated into the community. The transitional discharge model shares the responsibility between the hospital and community agencies to see through a coordinated plan or a coordinated approach on an individual basis. Crisis beds. We learned that there was only one crisis bed for children and youth other than the hospital in all of Niagara region. I believe safe beds has perhaps over 12 at this point. But there's only one crisis bed, and we're asking for the Ministry of Children and Youth Services to review the access to a bed 24 hours in our system. More formalized diversion programs. Across Ontario, several hospitals with psychiatric services are working with their community to formally try to divert persons who actually are at the hospital, on site of the hospital, that they possibly intervene to provide community support services right on site without being admitted and even not being admitted to the ED. So this is something that's under discussion. Service recommendations. The Quest program, again, this report will be, if you go through Niagara Connects and you Google crisis services, the full report will be on Niagara Connects, and what you'll see there is also recommendations around the Quest USAT. This is a urgent primary care crisis program for persons who need to be urgently connected to the system. Unfortunately, the program works very well, but it's limited right now to St. Catharines and I believe Port Cobourg. But there's equally enough demand for those services in Niagara Falls and Welland. So we're trying to hopefully support the expansion of that. Another one, primary care and psychiatric support. If that were provided more to community agencies such as safe beds, there's an opportunity to keep the person in the community longer. But at this point, it is problematic, and so safe beds and others are looking at possible answers to that to try to have that support. The emergency shelter system. Although the Niagara region is obviously moving on a home-first model, everyone should have a home, and that's fully supported. We still have gaps in our emergency shelter system, and one of the biggest ones is the need for emergency shelter for men in Niagara Falls. There is a temporary one there, at least that we last learned of, and we're hoping that can be moved to a permanent shelter in the falls. CMHA Coach program is a unique program that helps shelters and their staff cope with clients with mental health and addictions problems. And we hope that would move to be expanded. Finally, just to wrap up, a few system recommendations. Overall, and it's in line with the charter that George mentioned, and in particular Principle 3 of the charter, we need to overall enhance the coordination and integration between the transition points of care. And I'm really pleased to see that that's actually happening now. We need to enhance supports in the community to reduce high rates of ED visits. And just as a footnote, the Niagara region has one of the highest, if not the highest, readmission rates for mental health and addictions in the hospital, not only for the ED revisits, but also for the inpatient wards. And this is sort of a flag that at least now we need to move on with the types of integrated community supports that are necessary. And in so doing, more emphasis on partnerships and shared accountability for system outcomes, and how that would transpire. Finally, the need for system evaluation. Many agencies have corporate plans and corporate evaluations, but I found a general lack of evaluation on a regional basis as a system. How can we actually design a new system to achieve system-related goals? And finally, 3 to 5 year strategic plan suggested to be developed to implement some of the priorities, not only in the crisis report, but also in other related services. Anyway, thank you very much. Appreciate it.
Thank you, Ernie. We're passing over to Lindsay Galipeau now, who's going to speak to the Mobile Crisis Rapid Response Team. I'll hand this over to you.
Thank you. Excuse me. So my name is Lindsay Galipeau, and I am one of the mental health workers that is working with the police officers on the Mobile Crisis Rapid Response Team. Where's my mouse? There it is. Alrighty. Yeah. So this is to put it very simply. We have a police officer paired with a mental health worker, and that's what the Mobile Crisis Rapid Response Team is. So the goals of the program. The goal of the Mobile Crisis Rapid Response Team is to divert people from the hospital where appropriate and connect clients to community services from which they can access support. Once clients are aware of and connected to community services, they hopefully will be better equipped to cope with future crises and be able to connect with services before the crisis gets to the point that they need to call 911. Clients who are assessed to be at imminent risk to themselves or others will still be brought to the hospital if the crisis cannot be diverted or de-escalated. So now I'm just going to speak to a little bit to the process of how this program does unfold and what happens step by step so everyone can get a picture of what exactly it is that we are doing with people in the community. So the individual in crisis or those witnessing the crisis place a call to 911. The caller provides the call taker with a brief description of the crisis taking place. Dispatch will inform the Mobile Crisis Rapid Response Team of the call and a brief description of the crisis. The Rapid Response Team is out on the road in a police car at this time. The dispatchers request the team when a call is identified or speculated to be related to a mental health crisis. All right, we're going to be on this screen for a little bit. So when we get out into the community and we are meeting with a person in crisis, these are the pillars of what we're doing here. And I'll just give a brief description of each activity and kind of how we go about doing those things. So we do attentive listening to the person in crisis or the person witnessing the crisis, explain the situation. We show people empathy to the person in crisis or the witness. We do some reframing of statements, focus on being connected through facial expressions and body language. We validate the person's feelings. So we really do show the individual that we're hearing what they're saying. We're able to normalize their emotions and their reactions when they are congruent to the stressors that they're experiencing. So able to say, you know, it sounds like that's a really, really tough, and that would be very difficult for anybody in a situation like you're in right now. And we find that goes a long way with helping people feel understood. All the while we're talking to the person, we do a brief mental status examination. So this is kind of encompassing their state through our conversation and not necessarily specific questions that we ask, but we're looking at things like appearance, attitude, behavior, speech, affect, mood, thought content and process, perception, presence of hallucinations or delusions. Are they suicidal? If they are, is it in the ideation phase? Is it passive or is it actively suicidal? Or are they homicidal? And is that ideation passive or active? We're looking at someone's orientation to the time, their place, and their self, their level of concentration, any insight they may have to what they're experiencing, and where their judgment is at. After we've had this conversation, we're able to make appropriate referrals and complete a needs assessment. So what does this individual need right now? Do they need to talk to a mental health worker for some grounding techniques? Do they need connection to a crisis line or services? Maybe they're not aware of them yet. Connection to counseling, saying, hey, there's a place you can go tomorrow, that urgent support services that can help you with this, and maybe they're confident with that. Do they need housing? Do they need more of a case management style help? Or do they need to be at the hospital? I keep losing my mouse here. Where is it?
Hard to see sometimes.
There you go.
Yeah. Okay.
Sorry, we're just going to move on to the next slide when I find the pointer.
Yeah.
There we go. Okay.
There you go. Okay.
All right. So partnerships. So these are the places that we've created formal partnerships with. So we have Safe Beds, Coast Niagara, Salvation Army Booth Center, Urgent Support Services, Niagara Health System, primarily Psychiatric Emergency Department, and Pathstone Mental Health. So we've entered into service agreements with these agencies to help provide clients with warm transfers and appropriate care. The Rapid Response Team maintains close relationships with other community agencies as well that can be helpful to the clients that we serve, such as the YWCA, Southridge Community Shelter, and the Mental Health and Addiction Access Line. So just because we don't necessarily have a formal partnership on paper, we're still working very closely and very well with these agencies. So now just to look a little bit of what Ernie was speaking to earlier about the key mapping recommendations. So I want to talk about how we've actually executed these recommendations through. through the startup of the Mobile Crisis Rapid Response Team. So the rapid response team went to community agencies and we approached them and said, we need to put some referral protocols in place to best serve the client's needs prior to the launch of the program so that once we start, this works and it's working and we're working together as a community. So these protocols help the referral process run smoothly and contribute to smoother continuity of client-centered care. The strong partnerships that Rapid Response maintain with COAST and community outreach, that's the community outreach and support team, and PERT, which is Psychiatric Emergency Response Team, are essential to track our connections to service. So if we don't have these partnerships with the hospital and with COAST and other community agencies, we're not able to track that. So we need to make sure that that's very, very strong. So as Ernie was speaking to earlier, he was talking about a referral form that the community uses to refer someone to the hospital. So we have that. It's called a PCR, or a Priority Community Referral Form. And the mental health worker in the Mobile Crisis Rapid Response Team will fill that out and give it to the Psychiatric Emergency Department. And that's asking questions, why is this person here? Are they a danger to themselves, others, or is there another reason? And it gives us a place to explain what was going on in the midst of that crisis. Because oftentimes, the person's thought process might change by the time they speak to the PERT team. So we're able to provide them with that transfer of care that shows what the client was experiencing. PERT, Psychiatric Emergency Department, then returns to the mental health worker that brought that person in a transitional discharge form. And that helps us track the outcome of the psychiatric emergency visit in connections to services that may have been made. COAST then calls each rapid response client to follow up with them after the crisis. And that can either be, hey, how are you doing? We saw that this has happened. How can we help you? Or to say, hey, this is who we are. This is what we do. And we want you to call us next time you're in this place because we're here to help you if they're not familiar with that service already. And then the mental health worker from the rapid response team will do follow-up with COAST to determine whether or not that COAST has connected with the person. Just one more piece here. So community assessments are also integrated into the care plan for each client. Rapid Response, as I spoke to earlier, uses brief mental status exam. And we also use a TAG assessment, which stands for Threshold Assessment Grid. The TAG is used to help assess the severity of a person's mental health problems and examines things such as safety, risk, needs, and disabilities. And the assessment helps Rapid Response suggest next steps and possible referrals for the client in crisis. So this is what we've done so far, and this little brief explanation here captures the first 3 months of the program. So this would be the statistics as of September 30th. So as of September 30th, we had done 200 mental health calls. The average time for a person from calling 911 to actually being connected with the rapid response team, so speaking to the mental health worker, was 7 to 10 minutes. We had 121 diversions from hospitals, so those are people that didn't even attend the emergency department. And then 132 of those individuals were actually connected to a service. So 132 out of 200. I want to explain what would constitute a person not connecting to service. That would be if COAST were calling to follow up and they just didn't answer their phone, or they answered their phone and said, I'm sorry, I'm not interested in this service, or they didn't actually make that connection after we saw them, or maybe it wasn't even necessarily something that they were wishing to connect with someone with afterwards. They just need to speak to someone in that moment. So that's where we're at with our connections to service, is 132 out of 200. And that's all I have. Thank you.
Thank you, Lindsay. And before we proceed to some questions, just a few concluding remarks, and we'll take questions. We're well on schedule here. One of the purpose of the webinar, as I mentioned at the beginning, was for us to develop an awareness of our cooperative system of crisis care in Niagara, and all of that stemming from the charter. We realize that the charter is a living document, as any strategic plan or operational plan should be. So continuously in action, continuously changing as we continue to evolve our services. And the charter and its principles have really influenced the development of a number of initiatives including the access line, crisis mapping, our mobile team, and the work of transitions between the hospital and community services for mental health and addiction. So hoping that that you realize the importance of the Charter in helping us to have a common vision as we move forward in Niagara for mental health and addiction services. The mapping project that was led by Ernie, we need to have a community-wide overview of services. For those of you that are involved with the LIN and some of the work on Triple AIM, they certainly talk about population health and looking at the entire population and what the needs are. So we do need to focus on our population as a whole as we begin to identify key linkages and service gaps. As a result, we need to begin that work on bringing our sector together through some shared information, protocols, some enhanced access to services, and ultimately better services to clients. So it's not about any single agency or even some grouping of agencies, but all of us together, and that includes family members and, of course, the people we are here to support, citizens of Niagara. Finally, you saw the Charter in action as it was developed through the mapping exercise and our mobile team. It was established as an immediate intervention for mental health and addiction services. There has been good collaborative relationships between the police and other services, and I'm very pleased and actually very excited about the relationship, for example, that we have and the support that we have developed with the Niagara Regional Police and the NHS. Everybody wants this to work together, and the reason they want it to work is because it takes the load off of everybody, a load that we've all been carrying, and ultimately it does provide better service for the people we're here to serve. First and foremost, it's about the clients getting that immediate service. It also does serve our broader needs to link with community needs and for our mobile services to only use the hospital when absolutely needed and maintain people in the community as long as we can. So those are some concluding remarks, and we will take questions now. As I mentioned at the beginning, you may want to think about in terms of questions what you think is missing in crisis care, what are we doing right, or any comments on what should we stop doing in terms of crisis care in the community.
There was a question about the use of, and I apologize, the use of acronyms in my slide presentation. And yes, in fact, I had to go back to my glossary of terms in the full report for a couple of them. But the full report has a full page of the acronyms, and that should make it a lot easier.
Yeah, so everything's explained in the report, which you'll find on the Niagara Connect site. We do apologize for using acronyms. We're so used to it, we don't even think about it. It's like talking a second language, so our apologies. But Ernie has defined everything in his report.
Absolutely, and Sarah has put a link to that up in the chat pod there as well. We do have a question comment here from Carolyn. As a community partner providing housing and support services to many clients dealing with mental health and addiction issues, who sometimes go into crisis and are sometimes admitted to hospital, what's the best process for us to be able to access the information regarding the transition plan when clients are released from hospital? In the past, our clients have returned to our supported housing without a discharge plan, and we'd like to be part of the planning. What steps should we be taking to be included?
Okay, it's Lindsay here from the rapid response team. So the question is, when somebody goes to the hospital and comes back, you want to be part of the plan of that discharging. Is that right?
I think that's what I understand it to be. Yeah.
Okay, perfect. So the best course of action, and from doing case management and working with the clients and working closely with the hospital, my suggestion would be to be on consent with that client while they're in hospital, and get in contact with the unit that they're staying on, and then talk to their nurse and plan a meeting about being part of that discharge planning. In the past, that's something that we've done at CMHA, and it's worked well. Otherwise, just getting in contact with the hospital would be very beneficial from that aspect. Also, if you call the Mobile Crisis Rapid Response Team, we might be able to assist you in that and kind of advocate for that on part of your side when we bring them into the hospital and say, this is where this person is staying. You would then be their ICL, which stands for Integrated Community Lead, and we would put you on their form when we're bringing them into the hospital, and they would be getting in contact with you once that person is ready to leave the psychiatric emergency department.
Wonderful. Thank you, Lindsay.
You're welcome.
Ashley has provided a bit of clarification or comment around the USAT team from Quest specifically about the services there, stating that USAT can support clients over the entire Niagara region. So they're an urgent service that helps clients connect with community services available to them. Quest is a primary care center available to St. Catharines residents only. So hopefully that helps with some of the clarification for people. And Ashley also had a question, also wondering if there are any plans to open an emergency shelter in Welland. There seems to be an absence of such a service in that area, and it is greatly needed.
It's Ernie. At the time of the report writing, we understood there was a limited number of emergency shelter beds in Welland at a local hotel on a temporary basis. Whether that'll become permanent, I'm not familiar at this point. But I could ask George if he has any information about that.
I happened to be at Hope House yesterday speaking to them, and they were the ones that were operating the emergency shelter at one time. And there's no plans right now that I'm aware of. Unfortunately, it was an issue of funding. But, yeah, there is a need.
Absolutely. So any other missing services or gaps that participants on the phone have recognized with respect to crisis services in the region, or as George had said, what's working really well? What do we need to strengthen or build on? We'd love to hear from you. And if you do want to make any comments verbally, you can do so by unmuting your phone line by pressing *7 for those that don't like the typing quite as much. I have to say, from my own just personal experience listening to your presentation today, Lindsay, it was really great to have that balance, not only of looking at a system level and hearing about the report and the recommendations from Ernie, but also hearing what this looks like for you in your day-to-day practice. So that was really interesting for me as a takeaway, just to kind of get a real sense for the daily practice of this service. Thank you.
Thank you.
We do have a comment from Sue here. Just a reminder that while we do long-term care trauma counseling at CARSA, we also provide a 24-hour crisis line.
And just to jump in on that, with the Mobile Crisis Rapid Response Team, that is something that we have in the past and will continue to inform people in the community about if they're not aware of it, or remind them that that's there and a great resource to use if that is a service they require. So thank you.
Perfect. It's great to see the integration of so many of these services and making sure that we're actually, as I said, building on the strengths of the community and using services and programs appropriately. Very cool. Any other questions or comments from participants on the phone?
I'll just say quickly as well, working on the Mobile Crisis Rapid Response Team, if you have clients that we've interacted with or have questions or want to get in contact with us, I do an office day once a week, so I do have time to connect with people, and if you'd like to, I'm sure you can give your information to the Niagara Connects people, and they can pass that on to me, and I would have no problem getting in touch if anyone wants to talk further about it or create new connections or partnerships. That would be excellent. So feel free to try and get in touch with me.
Wonderful. Thank you, Lindsay. And I actually just put up the contact slide there, so your email's up there for people to directly reach out to you. So as people are kind of thinking of or pondering some last comments, we are going to pull up some evaluation polls on the screen just as we wrap up the discussion today. So please take a moment to answer those. If you aren't already a part of our Niagara Connects distribution list and would like to receive information from our bi-monthly newsletter and or information about these future events like this, please do sign up. Sarah's just posted the link there in the chat pod, and we've already got quite a schedule shaping up for 2016 with a webinar in January on January 20th about the Center for Excellence in Nonprofit Governance. So really exciting stuff happening, and if you'd like to stay connected to that and hear more about it, please do make sure that you're on our distribution list. Any other final comments before we wrap up, either from participants or from presenters? Oh, I do have a comment here from Mary. Where is the one crisis bed for children that you mentioned?
I believe it's Ernest speaking. It's in Niagara Falls at a Rotary Center. But just to confirm, if you wish to call Ellis Katzoff at Pathstone, I'm sure they can give you more information about that.
Perfect. Thank you.
We also have safe beds for those of you that aren't familiar with it. We have assigned beds for people with dual diagnosis, intellectual disabilities, at our Safe Beds program. And it's a partnership with Bethesda. We have a behavior therapist, we have a behavior therapist that comes in and provides support for individuals with dual diagnosis.
Wonderful. Okay. Well, we do have another couple polls that will be coming up, so please do take a couple minutes to hang on and answer those. But I just want to say a big thank you to all three of our presenters today for sharing this information with us, as I said, at both a system level and at the front line, what this looks like and where we go from here in terms of building on those strengths. So thank you very much. And to everyone who took the time to join us today, we really appreciate you coming on the line and participating in this webinar. And as I said, please do stay connected to us because we do have a lot of exciting events happening in the new year. So with that, I will sign off here. And thank you, everyone, and enjoy your afternoon. Take care.
Thank you.
Thank
Bye.
you.